Hi, everyone. My name is Dr. Marcie Fisher-Borne. I am the Managing Director of the Interventions and Implementation Team at the American Cancer Society. And for over a decade, we have been supporting HPV vaccine uptake efforts here in the US, as well as globally. I'm going to be speaking to you today about some of the challenges with implementation and what strategies we know work for successful HPV vaccine uptake. And just to give you a roadmap of the conversation, I'm going to start with talking a little bit about why this work matters. We're going to look also at implementation science, how it does help us think about HPV vaccine strategies. I'm going to talk very briefly about some of the high-level strategies we know work and share with you vaccine resources that are going to be able to help you as a provider, your health clinic, and your health system. Our HPV Vaccinate Adolescents Against Cancers program is a national program to increase HPV vaccine rates here in the US, to eliminate missed opportunities, and to make sure we continue to address geographic disparities when it comes to HPV vaccination. At the heart of our work is the ability to convene and catalyze partners. And while we do that on many levels, our conversation today is going to focus on our work with health systems and providers like you. Before we get into implementation or talk specifically about strategies, I want to just talk a little bit about why this work matters, why it matters so much for you as a provider and your leadership. We know in the US that there are over 37,000 cases of HPV attributable cancer each year. We also know that the HPV vaccine can prevent over 90% of these cancers. When we look at cervical cancer, oral pharyngeal, anal, vulvar, vaginal, and penile cancers in the US, many of them are attributed to HPV. The majority of oral pharyngeal cancers that we have in the US are most commonly HPV-related cancers. These actually now in the US surpass cervical cancer. In addition to the over 37,000 HPV attributable cancers that we see here in the US every year, it's really important that the public also know that there are many other infections and conditions that affect both men and women related to HPV. That includes over 300,000 women who are dealing with cervical dysplasia every year, over 355,000 men and women dealing with genital warts, over 1 million cases of low-grade cervical dysplasia, and over 2 million women who are dealing with abnormal PAPs related to cervical cancer. So this is a considerable burden, given that we know that the HPV vaccine can address most of these issues. An HPV infection also causes a lot more than just physical impacts. They have harm. These include financial, social, emotional impacts as well. Data models show us that we could actually eliminate cervical cancer if we could raise the HPV vaccine rate to 80%. That's extraordinary. It's also critical to know that oral pharyngeal cancers have risen significantly. So while we've seen and made good progress at reducing cervical cancer rates, we see that over the last 20 years, the cases of oral pharyngeal cancer for women have risen by 1.4%. For men, they've risen at rates at 2.9%. The death rate for cancers of the mouth and throat has increased by 0.4% per year between 2009 and 2020 after decades of decline. This is something that we can address. So knowing a little bit about the burden is incredibly important for you as a provider to be able to have some of this data. Additionally, we also know for the last 3 years, as we have been dealing with the pandemic, that there have been additional burdens. In fact, since 2020, so since spring of 2020 through January of this year, we have lost 8.4 million doses that have been missed. And so what that translates to potentially is a generation of kids who have not had the vaccine. We know from modeling data that because of this loss, we are looking at upwards of a decade to be able to catch up to where we were. If we don't take action for HPV vaccination, there will be real consequences for a generation of kids. Again, we have a cancer vaccine. When it's given on time, we can prevent 6 different types of cancers. 2 shots is all it takes. Knowing this, as the American Cancer Society, we have engaged in health system partners and providers like you to look at how we can increase on-time vaccination. Our quality improvement year-long intervention projects secure leadership for practice change, encourage health clinics to embrace a culture of quality improvement, use data to inform projects, and implement evidence-based interventions. I'm going to say a little bit more about that. But just to give you a context of where I'm coming from in the work of ACS, since 2015, the American Cancer Society has been partnering with health systems around the United States on quality improvement interventions to increase HPV vaccination. To date, we've worked in over 2,200 clinics, and this is a framework for which I'm going to be talking about for the rest of our time. Before we look specifically at some of the interventions, I want to talk a little bit about implementation science, what we know and how it's useful. And to give you a sense, I'm going to start with a story. So when ACS started this work, and when I started as part of their team, many years before the pandemic, we actually did field visits. And one of those field visits was to a large federally qualified healthcare center in the Deep South. There's some things we know about the Deep South. There are higher levels of HPV attributable cancers. We also know that there are lower levels of HPV vaccine uptake. This clinic had a lot of things working in its favor. It had a strong clinical champion. It had C-suite leadership. It had a new EHR, and it had a strong, committed quality improvement team. All of these things really critical for a successful project. It also had data from their immunization registry, which sometimes didn't match the data from their EHR. Also, when it came time to figuring out who is the client, who is the patient that needs the vaccine, they would have to go to a series of file cabinets, pull out a record, and see if that record matched the EHR record, and then also showed up as a patient that needed the vaccine in an immunization registry. So 3 different data sources. Oftentimes what happened when a nurse were to pull this data was that they would end up here in the picture that you see on the screen, which they called the vaccine box. This was often the place where confusion went to die, not really figuring out what to do around that particular client, that particular patient. So when we talk about implementation, we're talking about understanding and solving for things like the vaccine box. What is the patient that needed the vaccine? How do we know it? What if the systems that we have in place are telling us 3 different things? So solving for that problem is part of what implementation science tries to do. There is no single definition for implementation science. In fact, in 2015, Thomas O'Neill and colleagues published a review that showed 73 unique definitions. And the Implementation Science Best Practice Initiative conducted a survey that showed across 27 international organizations, there was no single definition. So implementation science has many names: implementation research, improvement science, quality improvement, action research, operational research, real-world research. Knowing that there are many different ways of framing implementation science, what does it actually mean? How do we define implementation science? So this is an emerging interdisciplinary field, and terminology matters. So I'm going to share some specific definitions for you to consider. The first is from the National Institutes of Health, which defines implementation science as the study of methods to promote integration of research findings and evidence into healthcare policy and practice. The National Cancer Institute takes it a little bit farther and saying, yes, it is a study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies, but doing so really to improve the impact on population health. So the reason we study methods ultimately is to make sure we're driving public health outcome change. Final definition I'll share comes from the implementation science team at University of Washington. Implementation science is a systematic scientific approach to ask and answer questions about how we get what works to people who need it, for as long as they need it, with great speed and fidelity, efficiency, quality, and relevant coverage. Perhaps the cleanest definition that I've seen, and really in the form of a question, comes from Dr. Karen Emmons at Harvard School of Public Health. How do we make sure what we know is what we do for everyone in every setting? One of the things that's great about the framing of this question is that the health equity piece, how are we making sure that the things that we know work are for everyone across all settings? We know that context matters. This long-term saying that many of you have probably heard, and this comes from 2 decades ago, some work done by the National Academy of Medicine that looked at how long it takes to get research to patients. It's estimated that it takes actually 17 years to get about 14% of research into the patient delivery system. That's a problem. So implementation science has come into being in part to help us understand how we translate what we know to what we do. So the strategies that I'll be talking about in a second, those strategies are our evidence-based implementation efforts. Those are the what. Implementation science studies how. Is what we're doing feasible? Is it feasible in specific contexts? Is it feasible for our patients in our community? Is what's feasible in a pediatric clinic the same thing that's feasible in a family medicine clinic? Can we do what we did in a pediatrician practice, in our family practice, in our family medicine clinic? So these are all the kinds of questions. What are the costs? Is uptake happening? If it isn't happening, what are the barriers? These are the types of questions that implementation science asks. When we look at the HPV vaccine and the work that ACS has led, that implementation framework really is around quality improvement. So our work has been partnering with health systems to look at how do we improve cancer outcomes through a QI lens. So QI is how we do our work, looking at continuous quality improvement in the healthcare space, and the evidence-based interventions are the what we do. They're the strategies. And the tool that we've used to sort of bridge these two pieces, the what and the how, is our STEPS guide for increasing HPV vaccine in practice. And through this webinar, you'll also receive a link to this guide, which can also be found on cancer.org/HPV. But the STEPS guide is both a toolkit for the steps of quality improvement that are going to move change, a roadmap of the intervention strategies, and curated source of resources, not only from ACS, but from many partners around the US who've created tools that can help you with your practice. We're going to now turn to some of the strategies that we know work for improving HPV vaccination. And before diving specifically in the strategies, just for context, I want to share some priority research gaps that we know in the space of HPV vaccination delivery, because some of these specific interventions and strategies can drive change. So around 5 years ago, a group of experts came together in the US to identify what are the priority areas of research where we can grow and learn in ways that are going to improve HPV vaccination. The second most identified strategies was working with healthcare providers on quality improvement interventions. So right now, I'm going to give a high-level picture of some of those interventions and then dive into two specific examples. So in the space of evidence-based interventions, what we know works are really multi-level approaches. What does that mean? That means that when you think about your practice, your clinic, your system, you're imagining interventions that involve the patient, or oftentimes parents, in the case of a parent reminder, providers, interventions that are directed toward providers, and those that are around community access or systems change, that are looking at broader systems that need to change. And we have a tool, there's a resource link within these slides of strategies related to evidence-based interventions. And I'm calling it out now because one of the great things around this tool is that you can see what is the evidence, what's the strength of the evidence we have by intervention type for your consideration. But I'm going to highlight two here that we know absolutely work, where we have considerable evidence around change. And the first is around a strong provider recommendation. In fact, a provider recommendation is probably the single most effective component of impacting a parent's decision to vaccinate their children. There is significant data across multiple countries and much in the US that help us know that training providers on a strong recommendation is really the beginning of where a health system should start, and making sure that providers have the resources, the messaging, the tools to make a strong recommendation. The other piece that I'll point out in terms of research gaps, we know that while QI interventions and the provider are critical, that the medical team, which includes MAs, mid-level providers, nurses, all of the ecosystem within the health system matter as well. So just wanting to make sure that we point out a resource available to you for that all system staff approach. So we want providers to be trained. We know that their recommendation is critical, and we know that making sure from the front desk, when I as a parent walk in to the vaccine information sheet that an MA might hand me, to the conversation with the nurse, all the way to the provider who's going to come in and make a recommendation. All of those interactions matter. So what I'm sharing with you now is a link to the National HPV Vaccine Roundtable's Resources and Action Guide. Inside of this suite of materials, you will also find tools and action guides specific for office, administrative staff, nurses, and MAs, all of which can be really helpful at training your team. So when you think about provider, professional, all staff education, a few questions to consider. What type of training and educational activities has your system already conducted related to HPV vaccine? If not related to HPV vaccine, are there other examples of training that have happened inside your system that have worked? Are there lessons learned from those examples? What's the culture of your system in your clinic? Is it generally pro-vaccine? How do you know? How might you know? What's the perception of the HPV vaccine by providers and clinical staff? What's the perception of providers and clinical staff to start vaccinating at age 9? Have systems, clinics, provider rates ever been shared before? So in any context, think about broader immunization context. Have providers looked at their own rates of recommendation? Have they looked at clinic level rates? Have there been conversation around system level vaccine rates that have been part of educational opportunities? And finally, what existing mechanisms already exist for training that could support HPV vaccination related education? Is there a day a month that the clinic closes? Is there a virtual space that staff have become used to? Are there ways to capitalize on this existing infrastructure? Second strategy that I want to make sure to address today is around how we engage a parent. What are the ways that we remind a parent that their daughter or son needs a vaccine? First, I'll say embarking on a new strategy for parent reminders or for patient reminders. It's a really good idea to test that strategy out, potentially in one clinic or a smaller part of the system. So some of the things that you want to consider when you're thinking about parents and when you're thinking about how a patient knows they need a vaccine are text messages, emails, phones, mail, patient porters. So all of these things work. Some take more effort than others. So knowing what sort of infrastructure you have to potentially make a phone call for scheduling, really thinking through some of those things. In general, also imagining what are the appointment opportunities for you to make that recommendation? Are you utilizing not only a well-child visit, but are there opportunities at 6 visits, sports physicals, nurse-only visits? Are there promotional walk-in vaccination appointments that can be set up? Are there options to extend a regular clinic hour or add weekend hours for vaccination? If you or your clinic is connected to a school, are there school-based clinic initiatives that could be added? These are all considerations when thinking about the patient-parent reminder opportunities. So a few more questions just want to point out for you to think about. What's worked? What do you already know worked with reminding a patient that they are due for a vaccine or a parent? Are there platforms and systems that could be expanded to include HPV vaccination? Are all opportunities to promote and deliver the vaccine part of the portfolio of services you provide? And finally, are there any modifications that have been made during the COVID-19 pandemic that could also work as you think about expanding preventative care to include HPV vaccination? I want to just share 3 final thoughts on some of the implementation challenges we've seen with our health system partners over the last few years during the pandemic that are important consideration as you look at your clinical practice and your health system. And the first is around data. We know that even the basics of identifying your eligible patient population takes time. In general, if you're thinking about being part of a QI project, leading efforts within your clinic system, know that sometimes this data process of just getting the right people together can take 1 to 3 months from our experience. And one of our systems said last year to us, building data reports is not a simple task. It takes countless emails, several meetings between multiple individuals to ensure the data is pulled from the EHR, that it's accurate, that it's reliable. I feel like this is the biggest win. Knowing that even pulling the data in and of itself is a big success to be able to know who's your patient population, where your opportunities are for growth, where there may be missed opportunities. The second challenge that we've heard repeatedly, and in particular during the COVID-19 pandemic, is around staffing. Thinking about staffing as you imagine future projects and championing the vaccine is going to be important. One of our partners who's been working with us for 3 years shared that even though this was the 3rd year in the cohort, that the big surprise is that out of the 3 years, that this past year, 2022, was the most challenging. Staffing issues are a challenge. And finally, we know that there is parental hesitancy, and thinking through how to address it matters. Are there mechanisms within your clinic, within your health system, to address some of these challenges? What are some of the language? What are some of the messages you want to put forward around the vaccine? How do you continuously talk about this vaccine as cancer prevention and successfully address some of parents' concerns around the vaccine? One of the tools that we have within ACS to address some parental concerns are parent-facing materials. So what you see now on your screen are many resources that the American Cancer Society provides to you, go-to resources for cancer and cancer prevention, all of which can be found on cancer.org/HPV. So please find these resources, use them, they're available to you. I mentioned the STEPS guide earlier. All of these can be found on our cancer.org resource page. Thank you for your time today. For more information about our Vaccinate Adolescents Against Cancers program, broader information about our cancer interventions, please go to interventions@cancer.org, send us an email. Happy to share information about our work or to partner with you on your future HPV vaccine champion effort. Thanks.